talking about the endocrine system, especially focusing on diabetes, Addison's disease, and Cushing's disease, along with things like thyroidism, hypothyroidism, hyperthyroidism, all of that. Okay. So first of all, let's break down a couple of different terminology. First one we need to talk about is diabetes. So diabetes is a condition where you have high blood sugar going. Okay, you might have probably heard about it. Okay, people being on different medications called metformin, medications called insulin, if they have diabetes. There are two different types of diabetes. Do you know what those two different types of diabetes are?
Type 1 and type 2. And type 1 is insulin dependent, and the other one is, I don't know.
Yeah, the type 2, exactly. Yeah, very good. So type 1 is insulin dependent, which means that I cannot survive without insulin. I need insulin in my body. Okay. The type 2, though, is what we call insulin resistance, meaning that I can survive with the insulin resistance ones, remember, I can survive without the insulin, but my blood sugars are going to be high, but it's insulin resistance, which means my body is actually going to be resistant to the insulin that I already have. So that's the difference between type 1 versus type 2. Okay. You also can consider that type 1 and type 2 both are genetic. They can be inherited. Type 1 is something that people are born with. Type 2 is something that they develop because of poor diet, lack of exercise, obesity, etc. Okay. When you look at the organ that produces insulin, what do you remember as the organ that produces insulin?
Pancreas?
So in type 1 diabetics, the pancreas probably is not working, which is the reason why they have to have insulin being given to them. In type 2 diabetics, remember, the pancreas is releasing insulin, but the cells of your body are resistant to the insulin that you're receiving.
Say one more time for the pancreas.
So in type 1 diabetics, your pancreas does not produce any insulin because there could be damage to the pancreas, there could be inflammation there, or there's damage where those cells just don't function. In type 2 diabetics, this is where your pancreas does produce insulin, but your cells are resistant to the insulin that you receive. Okay, so my own cells, basically, think about the lock and the key situation. So I have to have a key to open a lock, right? To get into basically the house. So think about the cell, like every cell in your body as a house that you can get into. Every one of these cells have insulin receptors on them. And then you have insulin floating around. Think that the insulin has to come and fit into an insulin receptor to be able to allow that cell to open up so that blood sugar can go in. If the cell does not open up, blood sugar cannot go in. So if I don't have insulin, such as in type 1, I'm not able to open up that receptor. In type 2, I might have that insulin, but it may not fit correctly into that receptor, which in either case, that insulin receptor, it's not able to open up and blood sugar is not able to go in. So that is the concern there.
Okay. So you're saying that for type 1, they don't produce insulin and the cells will not be open and there will not be any insulin production.
The cells would not be able to open.
Yes.
Because there's no insulin. So blood sugar cannot go down. So blood sugar cannot go into the bloodstream. So that's the reason why you would see a higher amount of blood sugar in your bloodstream, because they're not able to go into the cells.
Okay. But however, in the type 2, they can produce the insulin, but they don't think they will fit it. So
correct. Like I said, the cells are resistant to the insulin. So the insulin does not fit into the the insulin basically does not fit into the, or it does not fit with the receptor, therefore insulin cannot go in, or blood sugar cannot go into the cells. And so you have blood sugar floating around in your blood vessels and high, because your blood sugar is not able to come down because the insulin does not fit into the receptor.
Oh,
In general, the signs and symptoms of high blood sugar or diabetes are going to be what? So you have basically 3 P's that you need to know. These are the 3 P's of diabetic. So we know that you can have polyuria, polydipsia, and polyphagia. Okay, these are 3 P's of diabetes. These are the 3 signs and symptoms of diabetes. Polyuria means what?
a lot of urination, I think.
Yeah, excessive urination.
Mm-hmm.
Okay, polydipsia means excessive thirst.
Thirsty. Okay.
Polyphagia means excessive hunger.
Hunger. Okay.
So you have 3
Three
things
P.
that you're coming in. Yep, your polyuria, your polydipsia, and polyphagia is what you're going to see with diabetes. Okay, so you're going to be very thirsty, very hungry, and you are going to have to go to the bathroom a lot. Okay, now, other than this, what might be other signs and symptoms that you might experience? Well, you're going to see that they tend to have, like diaphoresis. Okay, they could have nausea and vomiting. Okay, they could have abdominal discomfort. Okay, these could be other symptoms that tell me that they're having diabetes, but definitely the 3 P's I would remember.
So it's gonna be in both type 1 and type 2, right?
Correct.
So the diaphoresis is that the diaphragm was the what does
Not quite. It's sweating, excessive sweating.
okay.
Yeah, when a person is excessively sweating.
I think we covered that one in the first video. Okay.
The diaphoresis, right?
Yeah.
Yeah. Yes, we did. Okay, nausea, vomiting, and then abdominal discomfort. These would be the signs and symptoms that you might see. Okay. Now, over time, if diabetes is not controlled, it can cause you to have complications. I mean, complications, I'm talking about over time. So over many, many years of this person not having good diabetic control, of many years uncontrolled high blood sugars.
Mhm.
Okay. What you're going to have is you're going to have them develop something called peripheral neuropathy. I want you to break that down. Peripheral means not central, but more so your extremities, hands, and feet. And neuropathy means nerve disease. So peripheral neuropathy would mean nerve damage specifically. And nerve
Now
damage in the peripheral areas. So that would be your hands, your feet, okay, hands, feet, etc. Okay, that would be the peripheral neuropathy. Okay? Nerve damage in those peripheral areas. Now, you could also have something called diabetic or retinopathy. So this is where you have damage to the what? Look at the word
okay,
damage.
so this is with the eyes, I think.
To the retina
Right.
of the eyes. Yes. Remember, the retina is what? The retina is the area, the back of the eyes. The back of,
signal.
yes, back of the eyes where the light bounces off. So we're able to see an image.
Yeah.
Okay. That's diabetic retinopathy. The other thing you might see is nephropathy. Okay, when you look at nephro, what is it?
Kidney problems.
So kidney damage. So this is many reasons why patients with diabetes and of course other things like uncontrolled high blood pressure can end up damaging their kidneys. And if their kidneys get too damaged, then they can even end up on dialysis. And this is only, the dialysis only temporarily until they're on the kidney transplant list. So they could even go as far as being on the kidney transplant list. Okay. If the over time, and I'm talking about many years, this is, like I said, this is not sudden. All these things that we're talking about today takes many, many years for this to happen.
Okay. So for the nephropathy, is that because the level of the sugar level in the kidney is stuck or it cannot filter out the sugar or what?
So it's going to actually be because the sugar over time ends up damaging the blood vessels.
Blood vessels, okay.
Yeah, so the sugar over time ends up damaging the blood vessels, which then the blood vessels start getting broken down. So think about the blood vessels that are going off to your eyes. Okay, think about the blood vessels that are going to your kidneys, such as the renal arteries. Those start getting damaged. And that's because, remember, this sugar is very sticky. It's kind of going to start breaking down the blood vessels because, you know, when you're having kind of sticky sugar going around, it sort of kind of rips away and breaks off everything. So that's the reason why you would see that this is a complication of of diabetes, basically.
Okay.
So going down, we do have four types of insulin that we can give. Remember, insulin we can give outside synthetically, which is meaning I can give it as an injection. Usually it's mostly given as a subcutaneous injection. If you're giving it subcutaneous, remember to know the layers of the skin. The top layer of your skin is what we call the epidermis. Below that is the dermis, and below that is where the subcutaneous tissue is. So this is more your fat tissue. Okay, this is more your fat tissue. So when you're giving this injection, you're going to give this into the fat tissue for best absorption. Only insulin that you can give into the vein intravenously is an injection called the regular insulin, which is a short-acting insulin. This is the only insulin that you can give into the vein, okay, which is regular insulin.
Okay.
Now, let's start with the first type of insulin that we have. We have what they call, and I need you to remember this mnemonic. It can be very helpful for you. Ready, set, inject, and love.
Ready, set, inject, love. Okay.
Ready, set, inject, and love. And when it comes to pharmacology, this is good to remember as well. Ready is going to be for the first type of insulin, which is known as rapid-acting insulin. It's called rapid-acting because once you give it, it starts working within 15 minutes of you giving this medication. So it is going to drop your blood sugar quickly. Okay, and it's going to last in your body for about 2 to 4 hours. So generally, this is the insulin that is given before you start eating, before your meals. So think breakfast, lunch, dinner. Okay, that is your rapid-acting insulin.
How many times do you have to give them? 3 times?
It really depends on what the doctor says. Usually it's given with meals, so it's going to be usually 3 times a day.
Okay.
Yep. The next one you have is a short-acting insulin. This one is known as, like I said, in like regular insulin. This one is known as regular insulin. And the 2 types of regular insulin that you have are Humulin R and Novolin R. So lin. Okay, that can indicate that this is a short-acting insulin.
Okay. So this one is the one we give them in the veins, right?
I'm sorry?
Veins?
In advance?
No, in vein. V-E-I-A-N.
Artery
and vein.
Yes. Yeah, in the veins. So this can be given subcutaneous as well, but it can also be given into the vein. Okay, so it can be given into the fat tissue, but this can also be given into the vein as well.
Okay.
So you can give it 2 ways, basically.
Okay.
And this is the one where it starts working starts working on instead of 30 minutes. So once I give it, I want to make sure their food is at least in front of them because this medication does start working within 30 minutes as well. Okay, the other one starts working within 15 minutes. And the medications that was rapid acting was Humalog and the Novolog. So they have the log endings, Humalog, Novolog. And their human log is also known as, the brand name is Lispro, Novolog, the brand name is Aspart.
How should I remember those? Do you have any tricks that?
They are, I would remember this mnemonic: ready, set, inject, and love, and I would double it. So every time I start with 15 minutes, times 2 of that is 30. Times 2 of 30 is 1 to 2 hours. And then the long acting really is just gonna be the same thing. It's gonna be around the same thing. Your school will have different values. I'm just teaching you the regular ones. Okay, your school may have different numbers. Most schools do. So they have their own chart that they expect you to remember, but for the purposes of just studying for right now, this is what you're going to remember.
Okay.
Okay.
Times 2 and times 2.
Yep. And then the last one is the last one is the intermediate acting, which is 1 to 2 hours. So ready, set, and inject is intermediate acting. And this insulin is known as NPH insulin. NPH. And remember, after NPH insulin, you have your long-acting insulin, which is known as glargine or Detamir. And the brand names for that glargine is Lantus or Levemir for Detramir. And basically, this insulin stays within your body for 24 hours. It remains stabilized. It does not rise. It does not peak, but it stays within your body for 24 hours, providing full coverage. Okay.
So those 4 types, do we give them the 2 ways, or which one is through the veins and which one is through the subcutaneous?
All of them are subcutaneous. The only one that can also be additionally given through the vein is the short acting, which is the regular insulin.
Okay, perfect.
That's the only
And
one.
what does it mean, NPH?
NPH is actually starting for it basically means that it's not peaking any not peaking, but it basically says like it doesn't. I don't even remember the specific name. We just refer to it as NPH, but it basically means that it has a steady peak. It doesn't peak automatically, but it peaks steadily. Like it goes at a steady rate. Okay, with the NPH.
Okay.
They're also calling NPH cloudy insulin because of the way it looks. It may look a little cloudy when you look at the bottle. Okay? A little bit of pharmacology here. You do not shake insulin. You roll it between your fingers like this.
The
Okay?
tube.
You do not shake. Because if you shake it, it activates the insulin. So you always want to kind of roll or gently kind of, tilt. But you never want to like shake.
Okay. Good. So we give those things when a doctor prescribed to the patient, right?
Correct.
It depends on the situation of the patient.
It really depends on the situation. Yes, that's right.
Okay.
And
Great
pharmacology will
research.
go more in depth. Like I said, today we're just kind of introducing you to it. Okay, to the different types of insulin.
Yeah. Good.
Yeah. All right. So that is, and I'm gonna share actually one more medication. So remember, I said you have your type 1 diabetics and type 2 diabetics. In which type of diabetes is it mandatory that I receive insulin? The
Type 1?
Type 1. Type 1s cannot survive without insulin, so they absolutely need it. And then we also have medications. Remember, your type 2 diabetics, the first thing when their blood sugar is like high like that is we're not going to be starting them on insulin right away. We're going to try other medications for our type 2 diabetics. And some of these medications are known as anti-diabetic medications. Okay, and one of the bigger ones is metformin. You might have heard about metformin. It's a very, very popular drug. Okay, usually it's the first drug that doctors put you on when your blood sugar level is a bit high. Okay, and basically how this drug works is that it stops the liver from breaking down glycogen. Remember, your liver stores extra sugar as glycogen in your body. But this medication is going to tell your liver to kind of stop breaking down that glycogen. Okay, yep. So it stops the breakdown and storage of glycogen, which means that you're not going to be able to increase your blood sugars, when you need it. It'll stop that. So it also decreases the amount of glucose that is absorbed by the GI tract. So that's one of the reasons why it decreases the amount of glucose that is absorbed by the GI tract by causing you to have diarrhea. Okay, by causing you to have because when you have diarrhea, remember the food is going through very quickly, so it doesn't get enough time to get absorbed. So the sugars in your food doesn't get enough time to get absorbed into the bloodstream. And that's how this helps to keep the blood sugar low.
Lower. Oh, that's good. Yeah, it makes sense.
That is the mechanism of action. One of the side effects that people will complain about with metformin is, they have to constantly go to the bathroom.
So it just makes the medication, when we take that medication, it just break down and make its process depending on what we have in our body.
Correct. That means, it stops the breakdown. So what it does, it stops the breakdown of glycogen, which is stored sugar in the liver. It stops the breakdown of that because it doesn't, remember, we want with anti-diabetic medications like metformin, we don't want the blood sugar to go up too much. So it's going to stop the breakdown of glycogen, because if glycogen breaks down, we get more sugar. So it's going to stop the process of that.
Okay, perfect.
Because you're on diabetic medications, do you necessarily need to be worried about dietary and health lifestyle changes, even if you're on this medication?
I think so. With type 2, we should.
Yep, you should. Okay. Type 2 diabetics, we're going to be focused on them losing weight, eating healthy. Okay. And thereby they can once they start losing weight, they're actually able to get that blood sugar under control.
Yeah.
Okay. So just a lot of different things to keep in mind there.
Before that, Carrie, what does it mean, lactic acidosis?
Yep. So that is, unfortunately, every medication mostly can have an adverse reaction. So an adverse reaction is a reaction that is not a good effect. Like, remember I talked about side effects, like GI discomfort or diarrhea. That's a side effect. Weight loss is a side effect of this medication. So side effects are things that we can tolerate. We do not need to stop using the drug because we're having this. It's an expected side effect. Adverse reactions, on the other hand, are things that are not expected, or they are expected, but they are highly dangerous. So we do need to stop using this drug if they're having that. Okay. So one of the things that we might have is something called lactic acidosis. So what happens is that when your body is not able to kind of use glycogen, it starts breaking down other things. And that contributes to the byproduct of that breakdown, such as when if fat gets broken down, what happens is that it causes a lot of acidosis. It causes my blood to become more acidic, which is concerning. Okay, so that's what happens here. Okay, this is only one of the medications that are given for diabetes. Like I said, I'm not going to go into too much detail. There are definitely a lot of other medications as well that you can take as pills. Okay, and usually with type 2 diabetics, they're only put on insulin if none of these medications are working, or they're not being compliant with the medications, or they're just, it's just not working effectively. Okay, does that make sense?
Yes. No, I understand. I thought it's the same, like side effect and the adverse reaction are the same, but you said it's
Yeah.
But now I understand.
Well, to be quite honest, in some areas they will use it interchangeably. They'll say, "Oh, this is the same thing," but no, there's actually a difference between them. Because side effects are things that are expected. Adverse reactions are things that are not expected.
Okay.
All right, and remember, diet, lifestyle changes, these things can all help to improve diabetes. So just FYI, we're gonna move on to our Addison's versus Cushing's disease. Okay, this is a condition where your adrenal glands are affected. The adrenal glands are located.
Adrenal glands?
Do you know where they're located?
I think it was the kidney.
Yes. So they are located on top of the kidneys. Very good. Okay. And these glands produce a couple of different hormones in our body. They produce a hormone called aldosterone. They produce a hormone called cortisol. They produce hormones called epinephrine and norepinephrine. Today, we're going to focus on the aldosterone and the cortisol. Okay. Remember, when the pressure in your body, when blood pressure in my body drops really low, okay, it sends a message to the kidneys. The kidneys will go ahead and release something called renin. So my kidneys, there's sensors in my kidneys because my kidneys can sense that the BP is low. So the kidney sense that the BP is low, what happens? Well, if they sense that the BP is low, they're going to experience, they're going to have the release of renin. So renin is released from the kidneys. Okay, this renin goes and it goes through an entire pathway called, and this system is called the RAAS system, which is the renin, angiotensin, aldosterone system. Okay, this is called the RAAS. You will need to have a very good understanding of the system to figure out what's going on. So when your blood pressure drops, low blood pressure, renin is released to the kidneys. This, at the same time that renin is released, you have something called angiotensin being released by the lungs. Okay, I'm going to go ahead and actually give you a picture of what this may look like. Okay, the RAS system to help you get a better understanding. And here's a picture. And I'm going to go ahead and just post the picture on there. So, or I can actually just do it from off of here too. You're able to see the picture, right?
Yeah.
Okay, perfect. Okay. So, excuse me, not the, my apologies. So the angiotensin 2. So when the renin is released from the kidneys, the angiotensinogen, something called angiotensinogen, is released from the liver. So at the same time that my blood pressure drops, renin is released from the kidneys. At the same time, something called angiotensinogen is released from the liver. The renin is going to be like a mediator. It's going to chop that angiotensinogen into angiotensin 1. It's going to convert it. And then at the same time that happens, our lungs are going to release something called a angiotensin converting enzyme, an ACE. So the lungs are going to release something called ACE, and that is going to convert this angiotensin 2. Now, the angiotensin 2 is a great, hormone. So basically the angiotensin 2 will go to your blood vessels and it will tell your blood vessels to vasoconstrict. When it vasoconstricts, when something tightens up, does that increase your blood pressure or decrease it?
It increases.
It increases it. Remember, you're tightening it up. You're constricting. So when you're constricting something, it's going to tighten up. So blood pressure is going to go up.
Yeah.
Okay. At the same time, this angiotensin 2 goes to your adrenal glands, which are located where? On top of the kidneys, exactly. And it's going to tell the angiotensin 2 to release something called aldosterone. This aldosterone actually then goes back to the kidneys and it tells the kidneys to stop excreting or stop getting rid of the excessive salt and water. Because remember, the whole point of this whole thing is salt and blood pressure. So it tells the kidneys to reabsorb more of the salt and the water. And when we reabsorb salt and water in our body, our blood pressure goes up.
Low.
Does that whole process make sense?
Exactly.
Okay. So just to reiterate, I'm going to go through it again. This is a very important concept to understand because it will be addressed in many things. When you're learning about pharmacology, when you're learning about patho, this process is very, very extremely important to understand.
Do you mind if we go one time and then I can just go flow with you?
Yeah,
one
for
time?
sure.
Yeah.
Okay. So just to repeat it one more time.
Yes.
Yes. Okay. So we have the renin angiotensin aldosterone system. It all begins when you have a drop in the blood pressure or in the fluid volume within your body. And this activates the kidney to release something called renin. At the same time, the liver releases something called angiotensinogen. The renin goes ahead and converts the angiotensinogen to angiotensin 1. At this same time, the lungs release an enzyme called ACE, which is an angiotensin converting enzyme, which then helps the angiotensin 1 to convert to angiotensin 2. This angiotensin 2 starts doing the job that we need, which is to increase the blood pressure. It goes to our blood vessels all throughout our body, and it tells them to tighten up or vasoconstrict. When it vasoconstricts, our blood pressure goes up. At the same time, this angiotensin 2 also goes to the adrenal glands, which are located on top of the kidneys, and it tells the adrenal glands to release a hormone called aldosterone. So the aldosterone is released by the adrenal glands, and the aldosterone then is going to go ahead and go to the kidneys, and it's going to cause the kidneys to reabsorb salt and water, so then that our blood pressure can go back up. Okay, and that's how the RAS system works.
So it goes both in the blood, to the vessels and also to the adrenal
Correct.
gland.
Yes.
So both ways we can increase our blood pressure.
Absolutely. Both ways you can go ahead and increase your blood pressure. Mm-hmm.
That's
Awesome.
good. Yeah, I got it.
Okay, so this is a RAS system. So now let's jump back into this part right here, which is Addison's versus Cushing's, okay? So what's happening in Addison's disease is that your adrenal gland that's supposed to release the aldosterone is not functioning. So it is not going to release the aldosterone, and it also, there's another hormone called cortisol, and it's not going to release the cortisol as well. So in Addison's disease, you tend to have a deficiency of aldosterone and a deficiency of cortisol. So think about what this can mean based off of all the things that we talked about. If I don't have enough aldosterone, do you think my blood pressure is going to be able to come back up?
No, it's going to be lower, I think.
It'll be low. So I'm going to experience hypotension, which is low blood pressure.
Mm-hmm.
Okay. And I'm also going to have hyponatremia. Okay. Hyponatremia stands this is another word, hyponatremia stands for low salt.
Oh, natremia.
Okay, it stands for low salt in your body, hyponatremia. You're going to have a low amount of salt, you're going to have a low blood pressure. Okay, and these are some of the things that you should be looking at when you look at that.
Mm-hmm.
Low blood pressure, low salt. Okay. At the same time, the aldosterone was also important in excreting out my potassium. So sort of sometimes in some situations, potassium and sodium work opposite to each other. Not in all, but some situations. So because we're seeing an decrease in sodium, we're going to actually end up retaining more of that potassium because the aldosterone is not working. So I'm going to see something called hyperkalemia, which is this word right here, which refers to high potassium, hyperkalemia.
Mm-hmm.
Okay. So blood pressure, is it going to be low or high when I have this Addison's disease, which is another way to say low aldosterone and low cortisol? Is it going to be high or low?
Low.
Blood pressure is going to be low, exactly. Is the salt level, is it going to be high or low?
Even the salt will be low.
Low, hyponatremia. And would the potassium be high or low?
Uh-huh.
The potassium would be high or low? I'm sorry, I didn't hear you.
You said it can go the opposite, so maybe high. The potassium.
High, exactly. Hyperkalemia is a word for high potassium.
Okay, so is it only in here in Addison disease, the potassium and sodium opposite, or it can happen in
it could
other?
be some other situations as well. It could be, like I said, not in all situations, but in some situations it will be opposite. But it's because the aldosterone is really being affected, or the adrenal gland is really being affected. The aldosterone is being affected because normally what aldosterone would do is it would help to retain salt and water, and it would help to decrease, because once you get more salt and water in your body, aldosterone actually causes the potassium to leave. And obviously we don't have enough of that aldosterone today. And that's the reason why we're having the retention of the potassium, but we have the salt and water leaving our body.
Okay. Mm-hmm.
And remember, we also tend to see low cortisol levels. Okay. Low cortisol
Mhm.
levels. Cortisol is a very important hormone that is released by the adrenal glands, cortisol is oftentimes released when you're very stressed. It's a stress responder. It decreases inflammation and things like that within your body. It's think about cortisol as like the steroid that you would have internally within your body. Okay, and it is known as that. It is known as a corticosteroid. Okay, so
Mhm.
think about cortisol as an internal steroid that you have in your body. If I have low cortisol levels, the higher cortisol levels that I have, the higher my blood sugars can be. But since with this condition,
Mhm.
our adrenal gland is not making enough of this cortisol, I can end up having hypoglycemia, which is low blood sugars. Okay.
Okay.
Another thing that you might see on their skin is this bronzy discoloration, which means their skin is going to look more like bronze. And I might even show you a picture to see what that kind of might look like. Yeah. It's really hard to tell with this one, but this, you can see they look more tan. If you can look on here, this is more that bronzy discoloration, more like tan, tan skin tone that they can have. Okay, which is that bronzy sort of
Okay.
discoloration. Oops, bronzy sort of discoloration that they can have.
So this is because of high cortisol?
This is because of not high, but low cortisol and low aldosterone.
Okay.
Remember, in adrenal gland insufficiency, that's what you're having: low aldosterone and low cortisol. And because they have low salt, these patients are going to have salt cravings. They're actually going to be craving for salt. They want more salt in their body.
Yeah.
So at the same time, before we talk about treatment intervention, let's talk about the opposite of this. The opposite of this condition is something called Cushing's disease.
Okay.
Okay, so if easy way to remember these conditions is if you remember one and you know that it's the opposite of that one, you just remember that's the opposite. Everything is opposite. So in Cushing's disease, basically, this is where you have a high amount of cortisol specifically being released. Some of the aldosterone is high too, but mostly the cortisol is the one that's high. See, just think C for Cushing's, C for cortisol. Okay,
Okay.
think A for
Okay.
Addison's, think A for aldosterone.
Adrenal. That's yeah.
So usually if you have a high cortisol level, some of the signs and symptoms that you can tell that this patient is having Cushing's is because they tend to gain a lot of weight. Okay?
Okay.
Remember, with Cushing's, you tend to start seeing things like obesity happening because of this high cortisol. You especially develop something called truncal obesity, which is obesity around your central part of your body, like your abdomen, your kind of just chest area, all of that. Okay, truncal obesity. Okay,
Tranquil. Okay.
truncal obesity. Your skin does become more fragile though, so your skin becomes more thin.
Okay.
And you are at increased risk of infection because cortisol is something that is immunosuppressive. So I'll write that word down here,
Mhm.
immunosuppressive, which means that it suppresses or it decreases the effectiveness of the immune system. So that's why it's called
Mhm.
immunosuppressive. So if I suppress my immune system, I'm more likely to have risk of infection because my immune system is
Yeah.
suppressed. So I'm more likely to get an infection. Okay, do you need me to slow down or are you okay? Lydia, are you there?
Yes, I'm here. Did you
Okay.
ask anything?
Oh, I said, do you need me to slow down or you're okay?
No, you're good. You're
Okay.
good. But maybe I'll ask you later when you're done.
Okay, sounds good. Okay, so with the Cushing's, you're going to see more poor wound healing as well. Wounds are not going to heal that well. Like I said, your skin's gonna be more paper thin. And I'm gonna show you a picture of a person that has Cushing's. They're gonna sort of look like this.
Mhm.
Okay,
Oh,
this is what they're gonna look like. Okay, like very
oh,
obese looking, a lot of fat around the central region, Okay. They tend to have poor wound healing. They might also tend to have bruising on the skin. So I would write that down.
Mm-hmm.
Bruising on the skin. Their face, they would call this face what they call as a moon face, a very round face. So they would say it's like looking
Oh,
like a moon face. Okay. So that's what you would see. A moon face, you would see also a buffalo hump. So if you look on here, they call this a buffalo hump. I know it sounds really mean the way the words that they describe to use
yeah.
this, you know,
Mhm.
unfortunately for these
That's
patients,
best.
but yes, they are having a moon face, a buffalo hump, okay, like a buffalo. And they're going to have like a lot of obesity in the abdominal area on the chest. Okay. And you're also seeing stretch marks on their skin. Okay. Stretch marks,
Mhm.
striae, STRIAE. Striae would mean, so this is the word for stretch marks. Okay. Oftentimes you'll see a lot of stretch marks um, in women that are
Yeah.
pregnant. You'll see a lot of stretch marks
Yeah.
coming. Okay. This is striae. Okay. And oftentimes with the striae, this again is characteristic. So if we're seeing striae on the abdomen, it is characteristic of Cushing's. We could potentially see this as Cushing's coming on there. Okay.
Mm-hmm.
All right, let me go back here. Okay. Also, think opposite. So in Addison's, my blood sugar level is going to be low, so hypoglycemic. In Cushing's, my blood sugar level is going to be what?
Hi.
Hyper. Yeah, it's going to be high, hyperglycemia. My blood pressure is going to be low in Addison's, so my Cushing's, it's going to be, if in Addison's disease, my blood pressure is low, in Cushing's,
It's gonna be high.
it's going to be high blood pressure. Exactly.
Mm-hmm.
Okay, high blood pressure. Okay. So
Mm-hmm.
you're going to see poor wound healing. You're going to see that the blood pressure is high. You can see that the blood sugar can go up. So all of these
Mm-hmm.
different things can be happening as well. Okay. So
Okay.
that's Cushing's and that's Addison's. So a little brief intro. We're not going to talk about treatment interventions because I just want you to expose yourself to the different conditions here. So let's do a little question and answer, but Q&A before we move on to the next topic. So in
Mm-hmm.
Cushing's disease, is the cortisol level high or is it low?
It should be high.
It should be high. Okay. In
Mm-hmm.
Addison's disease, is it going to be high cortisol or low cortisol?
It's gonna be low.
Okay, very good. In Addison's disease, is the aldosterone level high or is it low?
So Addison is with A, so it's gonna be low
Low
aldosterone and
cortisol.
low cortisol.
Exactly. Is in Cushing's, what is the potassium level in Cushing's? What's the potassium
So
level?
it's gonna be low because it's the opposite of the Addison.
Correct. So it's going to be what? Hypokalemia.
Hypokalemia.
Kalemia. Yes, hypokalemia is low potassium. Okay. And then is the sodium level, is it going to be high or low in Cushing's?
And Christian is gonna be low, I think.
Nope, high.
Yeah.
Opposite. Remember, in Addison's, it's low. So Cushing's, it's going to be high. So
So we said
hypernutrition.
sodium. We said sodium in Addison is low.
Mm-hmm. And remember,
Okay,
that's
so
why
it
the
should
reason
be
they have
high.
salt cravings. They're always craving for salt because of that.
Okay, so Jory, for Addison disease, the if sodium is high, low, so
Mm-hmm.
the potassium should be high, right?
So again, don't think about it like that. But yes, in essence, yes, that is true. They're opposites. Mm-hmm.
Addison, yeah.
Sure. Yep.
And in question, so if
Mm-hmm.
the sodium is high, the potassium is gonna be low.
In Cushing's, if the sodium is high, the potassium is going to be low. In Cushing's, I want you to think opposite from Addison. So everything that you're
Yeah.
having in Addison's, it's going to be the opposite of that.
Okay, perfect.
Okay, in
Yeah.
Cushing. So in Cushing's, if my salt my salt level is going to be high in Cushing's because in
Cushing, yeah.
Addison's it's low, right? So I'm going to have high
Everything
salt in
is low.
Cushing's.
Perfect. Yeah. So I will, if I'm not correct, just if I'm mistaken, just make me a correction for that. So
Of
in
course,
addition, I would say that everything is low except the potassium,
exactly. Yep, good.
right?
Yeah.
And
Yes.
for the patient, it's gonna be the opposite with the cortisol, aldosterone, and
Correct.
potassium. No, sodium.
Yes.
Yeah, potassium. Yeah,
Yes.
potassium. Everything is high except sodium is low.
Correct. In Cushing's. In Cushing's, the
Yeah.
potassium, oh, or sorry, excuse me, Addison's, the potassium is high, the sodium is low, and everything is low. Blood
Yeah.
pressure is low, sodium
Um,
is low. Usually, I
yeah.
also want to kind of have an understanding of how salt and water work. Salt, sodium, think about sodium, right? Sodium is very
Yeah.
attractive to water. So
Water.
wherever
Yeah.
sodium goes, water tends to follow.
Mm-hmm.
So that's one of the reasons why, like, if you're seeing a high amount of salt in your body, that's also why there's a lot of water with that salt, because the salt attracts the water to stay within your blood vessels.
Mm-hmm.
Okay.
Okay.
If you look at your Addison's disease, that's also one of the reasons why having a low salt in Addison's disease means that you don't have enough of that water in your system because there's nothing for that water to hold on to. So that's the reason why you see a drop in blood pressure in Addison's.
Okay, I got it.
Okay.
Perfect.
So that's the basic Cushing's and Addison's, okay? Pretty good systems to have an understanding of and, kind of walk through and things like that.
Mm-hmm.
Okay. The next one I'm going to give you is your SIADH and diabetes insipidus, okay? I'm going to tell you, you're going to be way ahead of your classmates, actually, with knowing this information, because a lot of your classmates, this is a very big, hard topic. This influence and electrolytes, a lot of your classmates will get stuck on. A lot of people do. So, you're able to kind of get a good head start. So you already walk in knowing, these conditions as well. So that's going to be great.
That's what I need.
Okay. Okay.
Yeah,
So
thank you.
now we also have the two kind of conditions that are different too. Okay. So this condition, I'm going to walk through what the normal is. So let's walk through what the normal process is first before I talk about diabetes insipidus and SIADH. So anti-diabetic.
What does it mean, inspired this?
I'll talk about that in a second. Okay. Let me talk about something called
Okay.
anti-diuretic hormone first. Okay, so your anti-diuretic hormone, also known as ADH, okay, this is a hormone. Look at the word itself. Diuretic means to urinate out. You're leaving, diuretic means to urinate out. Okay, you're losing a lot of water through urination. Okay,
Mm-hmm.
anti-diuretic would mean against urination. Okay, so think about that word, anti-diuretic. So anti-diuretic hormone is released by your pituitary gland. Your pituitary gland is actually located here, up here. If you remember where the pituitary gland, and this and the hypothalamus is what we consider the master glands of your body. Here's a picture.
Mm-hmm.
Okay, it's located all the way up here. Okay, you have the hypothalamus, and then you have the pituitary gland right below that. The hypothalamus sends messages to the pituitary gland, and the pituitary gland basically controls all the different glands within your body. So just a quick overview here. These are all the glands in the body. Okay, picture here. Okay, I want to show you a picture where they actually have it labeled. Okay, so you have the pineal gland within your brain that helps to regulate your sleep. Okay, you have the parathyroid glands in your neck and the thyroid gland in your neck. And they're going to be, as we go through them, we'll talk about what the purpose of those glands are. You also have the thymus, which is located more centrally in the chest. The thymus is not going to be that important in adults. It's mostly more important in children. Then we, of course, have the adrenal glands, which are located on top of the what?
Kidney.
The kidneys. Yep. And we have the pancreas, which is actually also has two functions. It has a function of being a gland. And then we have the kidneys. Okay. And then we have testicles in men, and ovaries in females that are affected by the pituitary gland.
Mm-hmm. Perfect.
Okay. So with the antidiuretic hormone, this hormone is released by your pituitary gland. And what this hormone basically does is that it basically stops water from leaving your body. And again, this specific hormone is released when your blood pressure is low or when you have low fluid volume within your body. Because if my blood pressure is low, I don't want to lose much of that fluid. I want it to stay in my body.
Mhm.
Okay. Or when I don't have enough fluid volume, say that I maybe lost a lot of, I don't know, maybe I lost a lot of blood in a car accident. Okay. So my body is trying to conserve as much of the fluid as it can. So they're going to release antidiuretic hormone so I don't lose all of that fluid. Or maybe I'm severely dehydrated. So in that case, the antidiuretic hormone is released by the pituitary gland up in your brain, and it's going to go and it's going to say, okay, we need to stop. It's going to go to kidneys and it's going to say, okay, kidneys, stop releasing all of that water from the body
Mhm.
because I need it. So this is how this hormone directly normally works in your body. Okay, does that make sense? So
Yeah, yeah.
normally it helps to retain water in your body.
Mhm.
Okay, yes, makes sense.
Yeah, yeah.
Okay, now we're going to talk about these conditions, which is one is diabetes insipidus and SIADH. Do you think diabetes insipidus has anything to do with diabetes mellitus? What do you think?
I don't know the meaning of the insipidus, so I can.
Okay. So actually, it doesn't. There is actually not any correlation between diabetes mellitus and diabetes insipidus. There's no specific meaning of insipidus. If anything, it could mean that you are like, I mean, I would say that it could specifically, if you break it down, insipidus, it could be because that you are losing a lot of fluid or you're very thirsty. Okay, so
Oh,
it could be interchangeable like that. But basically in diabetes insipidus, what's happening is that you don't have enough of the antidiuretic hormone. You don't have enough of that hormone. So if I
okay.
don't have enough of that hormone, remember, I'm not able to hold on to water. I'm not able to retain water, which means I'm going to end up losing a lot of the water. Think about the antidiuretic hormone as almost like a police officer. It keeps everything in control. When I don't have enough of
Mhm.
that police officer or that antidiuretic hormone, all the fluid is going to leak out of my body.
Yes, you're right.
So if I'm leaking a lot of fluid out of my body, what is the urination going to look like? Am I going to have a lot of urination or very little urination?
Just a little bit because it's in our body. It's distributing in our body. It's not going to the proper way.
Actually, not really. You're going to actually remember this is working on your kidneys. So your kidneys have no policeman, they have no control. So all the fluid is actually going to
Oh,
leave your body because
the
it's
kidney.
anti-diuretic. Okay. And this is also one of the reasons why we call this condition diabetes because of the symptoms. Because remember, what did the three P's of diabetes mean? What do they mean? The three P's
Only
of
urination or
Mhm.
excess urination, excess thirsty, excess hunger.
Correct. Yep. So polyuria, polydipsia, and
Mm,
polyphagia. So you're not going to see polyphagia, which is extreme hunger, but you are going to see polydipsia, which is extreme thirst, because you're losing a lot of water, and polyuria, which is going to be excessive urination. Okay. Because they're having these symptoms, remember, they're going to become dehydrated. And if they become
mhm.
dehydrated, remember the salt in your body actually starts rising because remember an antidiuretic hormone only affects the water. So if I don't have enough of the antidiuretic hormone, it's not going to affect the salt level, but it is going to affect the water level. So I might end up having hypernatremia, okay, because I'm holding on to a lot of salt, but I don't have enough water in the blood
Mhm.
vessel. Okay, does that make sense?
Can you repeat the last sentence that you said about the salt?
So again, diabetes insipidus is when I don't have enough. When Lydia, give me 1 second, please.
Sure, sure, go ahead.
Okay, sorry about the interruption.
It's okay.
So with the diabetes insipidus, remember this is when you don't have enough of that antidiuretic hormone. You don't have enough of that antidiuretic hormone, which means you're not going to be retaining water. You're instead going to be losing a lot of water. So you will see polyuria, excessive urination. You'll be seeing polydipsia because you're losing a lot of water. You're very dehydrated, and you're going to see that they will experience hypernatremia, that high salt level. They will experience that because there's no fluid to dilute the salt. So the salt remains in your body, but you end up losing a lot of water. So think about this. Think about it. Think about it as the same scenario as when you are like mixing lemonade. Like when you're trying to make lemonade powder, you're mixing lemonade powder with water to make lemonade.
Mm-hmm.
The more the more water that I put in with the lemonade mix, think about the lemonade mix like the salt, and think about the water like the fluid in your body. So
Mm-hmm.
so if I put in more lemonade mix, my blood is going to become more concentrated, right? Or
Yes.
or the lemonade is going to become more concentrated. It's going to become stronger. If I
Mm-hmm.
put water, though, it's going to become very diluted.
Diluted.
Okay.
Diluted, yeah.
Or if I don't put enough water, it can also become very concentrated, because in comparison to the amount of water and the salt that we have in our body, it seems like the salt, there's a lot more salt because I don't have enough water. So basically you experience hyponatremia because there's just not enough water to dilute the salt.
Okay.
Okay, because remember, you end up losing a lot of that fluid.
Water. Okay. Yeah, I understand now.
Yep. And so the opposite of that condition would be known as SIADH. This is known as the syndrome of inappropriate antidiuretic hormone. SIADH. Okay. This is where you have too much of that antidiuretic hormone. So think about opposite of DI. So all the symptoms you're going to have are opposite of the diabetes insipidus. Okay. So do you think you're going to have low, or are you going to have a fluid retention or fluid loss in SIADH?
There's going to be fluid retention, not fluid loss.
It'll be fluid overload because you end up retaining a lot of fluid. Remember, you have too much of that antidiuretic hormone, so basically it's going to stop you from urinating any water out. It's going to retain every single piece of water in your body, which leads to fluid overload. Okay. And because I have all this excessive fluid, it's going to dilute the salt. So is my salt going to be hyponatremic or hypernatremic?
Hypo. It's going to be low.
Exactly.
It's going to be diluted.
Yes, it's going to be hyponatremic that you're going to see. Okay. And we also consider the fact that we're looking at something called the urine-specific gravity here. Okay, here's the word urine-specific gravity. This terminology is very important to understand because the urine-specific gravity is looking at the concentration of the urine, the amount of solutes within the urine, and the normal should be between 1.005 to 1.030. That should be the normal. Okay. When I'm having an issue such as this, what happens is that so say, for example, we go back to our diabetes insipidus. Remember, in diabetes insipidus, I lose a lot of water. So is my urine, is it going to be more dilute or is it going to be more concentrated?
More concentrated.
More dilute. So my blood inside of my body, I'm going to be more concentrated because I don't have enough fluid. But outside of my body, in my urine, I'm peeing out so much.
Oh, yeah. For the urine, yeah, you're right.
It's going to be dilute, right? So if it's dilute, my urine-specific gravity is going to be less than 1.005.
Yeah.
Okay. So it's going to be low urine-specific gravity that I have. On the other hand, opposite of that, what is it going to be? The urine-specific gravity for SIADH.
It's going to be greater because we have a concentrated salt inside the urine.
Exactly. So the urine-specific gravity is going to be is high. It's going to be the urine is going to be concentrated. because again, we're not losing a lot of fluid. Our kidneys are not excreting out a lot of fluid. Okay. So again, don't worry about the treatments yet because you will go over them, but I need you to just get an understanding of the conditions here.
Okay. But before that, so the urine specific gravity, the amount that we are saying is the amount of sodium, right? The amount of sodium in the urine.
No, it's going to be a mix of sodium, other solutes, like things like proteins. It's going to be a mix of all of that, not just sodium.
Okay, but it's the sum of all those things inside the
Correct.
urine, right?
Correct. Yes.
Oh.
Okay. So let me ask you a little question Q&A before we move on. Okay.
Yeah.
Am I going to see in regards to the blood heart rate, is the heart rate going to be high or is it going to be low in SIADH?
SIDH, I think it's gonna be high.
Okay, yes, the heart rate is going to be high. Very good. Okay. What about in your DI? Is the heart rate going to be high or low?
It's gonna be the opposite, so it's gonna be lower.
So this
So
is an
it's gonna
interesting thing.
be
So
bradycardia.
you may actually see normal or high heart rate in DI. Because, so this is interesting, right? So because your own heart may start compensating for the low amount of fluid within your body. The heart's very smart. Like I said, it's very smart, but it's also a little stupid because of the fact that the heart, oftentimes it tries to compensate for the low fluid volume by bumping up the heart rate. The heart doesn't realize that the problem is not that it's not working. The problem is that you just don't have enough fluid within your body. But it tries to compensate for that by bumping up the heart rate. So you could see a normal or high heart rate in diabetes insipidus. Okay. And in SIADH, you're going to see that high heart rate because you have too much of that fluid and your heart is just trying to pump all that fluid out as quickly as possible. So that's the reason why you'll see tachycardia in your SIADH.
Okay. So we will experience both the brady and tachy in the DI.
Mostly normal and tachy, and could be possibly Brady, but not really. Normally normal heart rate or tachycardic heart rate.
Okay.
What is a normal heart rate, by the way?
Heart rate, it is from 60 to 120.
Or 60 to just 100.
Oh, 100.
60 to just 100, exactly.
Mm-hmm.
All right, so the next one, oh, I guess my screen just disappeared, right?
Mm-hmm.
Oh, why did that happen? Give me 1 second.